Berapa orang semua? Dia semua dah 30-40 kan? 40 lebih ramai juga.
I think not all here because Shamimi tell that some of them have class that not finished yet.
Okay, so should I wait how long? 5 minutes? 10 minutes more? Okay, maybe we wait for them lah. We wait for 5-10 minutes more. Okay.
Yeah, okay.
Okay. Hello everyone, morning, afternoon now. Can you hear me?
Yes. Good afternoon.
Yes, Prof.
Yes, can Prof.
Okay, you all can see my slide, right?
Can Prof.
Yes.
Okay. Yes, this is the second time, my second lecture on something to do with the brain for you all. Wait. The wire stuck on my face. Okay. So brain networks. Talking about brain networks in psychosis. Psychosis basically is a schizophrenia. One of the disease with psychosis is schizophrenia. But psychosis can be due to many causes like drugs, medication, metabolic disorders and so on. But the one that I refer here is a schizophrenia. And talking about network for mania, mania is a manic depression. It's a disorder where the patient has depression, and at certain occasion the patient has also elevated mood. Elevated mood, it means mania, mood disorders, and anxiety. So basically all these, schizophrenia, mania, anxiety, involve a special network, a limbic network. And some people call it mood network. Okay? So the limbic system is the key here. And one of the very interesting network or anatomy that you should know. To be a professional in this field and in cognitive psychology and so on, limbic is a key. So the limbic system, important for you all, important for neurosurgeon, for neurologists, and so on. So to start with, it's a very complicated network. Involves many structures.
Sorry,
Hello?
Professor. Hello.
Yeah?
Would you please enlarge the slides, because right now we see all the slides.
Wait, okay. Yep.
It's very difficult. Thank you.
First, I just mumbling first. Okay. Here. So, talking about the network, is a limbic network, right? Limbic network is a key. Consists of very important structure inside the brain. You all can give one example. So, hypothalamus, thalamus, pineal gland, pituitary gland. So you see this gland, pineal and pituitary gland. So they have connection with the limbic system. So from this, you know that there's a endocrine or paracrine or hormones involved in the limbic system. So that's why the limbic, beside communicate through the nerve, is also communicate with other body part through the hormones. So that's why you have male and female profile. Sometimes hormones also determine your other organ function like kidney, heart, and hormone also determines your behavior, and so on. Okay, so to start with my lecture talking about the network. So just anatomical recap. This is my second slide. Anatomical recap. Remember this one. This is in general. You can see that the frontal lobe, something that you plan or you judge, involved in the frontal or prefrontal lobe. Okay, so it's a pre-planning area. It's a prefrontal lobe. Okay, and then this is my slide before. Just a recap. So this one, the doer, the motor one, and the sensation is behind here. But you can see the integrator or integration. Some people put it here, and some people put it here, integration as well. So the integrator 1, integrator 2, or some people put it as analysis component here. but it's a very general here. So the input here for auditory, visual, sensory, so all goes to the area and then integrate here. So this visual, sensory here, and maybe the lateral part is the auditory one. So the integration part is here. Okay, as I said before, hormones also play a big role. The two major hormones, pituitary and pineal gland. And the one that most is an automatic part. The automatic part, the one that you cannot control, you cannot hold it. Maybe you can hold it for a few seconds, but you have to let go. So this is a breathing center, cardiac center, heart rate center, blood pressure center. So this is a brainstem. Okay, the brainstem, which consists of reticular system, many nuclei, and the ascending and descending pathway, or ascending and descending tracks, or ascending descending white matter tracks. Okay. And the one before here, and the one behind here is a cerebellum. So the one that I gave a lecture before to do with coordination, balancing, accuracy. So it's always, this cerebellum always communicate with the motor system and basal ganglia system. Basal ganglia to do with the initiation of the movement, coordination as well, so balancing with the cerebellum. So where's the limbic actually? Limbic consists of the prefrontal area and this cingulate cortex. See the corpus callosum here? The corpus callosum communicate between right and left hemisphere. It purely white matter tracks. There's no nuclei. It's a purely white matter tracks in the corpus callosum. And above it, you see the cingulate gyrus. Above it's a cingulate cortex. So this is a very important area because it is inside. You cannot appreciate. So once you peel off the hemisphere right and left, then you can see it deep inside. Okay. And of course, the structure here, anterior to the hypothalamus, anterior to the lamina terminalis. So you have various nucleus here, septal nuclei, nucleus of Maynard, and so on. I give the detail later on. And move deeper, you have hypothalamus and thalamus. So the division between thalamus and hypothalamus is anterior, ventral. So anterior, downward. Okay, the thalamus is more like posterior, dorsal. Okay, remember for brainstem, the ventral here, the dorsal here. But for the cerebrum or diencephalon, this is a diencephalon structure. This is a mesencephalon, diencephalon, and this is a prosencephalon. So that's embryological term. Okay, so this cerebrum, the ventral is below, and the dorsal is above. So it's different from the brainstem and spinal cord. The reason because of the buoyancy, because of the microgravity bending. So in this area, you have the sulcus, division between thalamus and hypothalamus. A lot of nuclei here, a lot of nuclei in the hypothalamus as well. So then you can go down deeper. You see the mammillary bodies, like small mammillary bodies here, and down is a brainstem. This is a midbrain, it's a pons and medulla. Okay. See, the brain is a mushy brain, but it consists of everything. So you see, you can't imagine it's just only anatomy. So it must be something to do with beyond anatomy. So everything, even though it looks like mushy brain, but all in there. So very complex and marvelous, isn't it? So the most probably the best, the most complicated organ that you can study in your body. So look here. Just a recap before we go to the network. I mean, psychosis and so on. They are mostly involved the limbic system. But just to recap you here, this visual at the back, visual attention, motion here is a facial recognition here. Okay, so face recognition. So basically, you can roughly summarize like this. The what and the where. What is the object? Where is the object? So normally you have two pathway. Okay. So here is the what. When you see the face, who is that? Okay. Who or what? And where? Where is the who or where is the what? Okay. The table is in the class A. So that's the location where and what here. So when you see the table here, then you say the what question is here is going through this pathway. We call it inferior longitudinal fasciculus, ILF, communicate to the gyrus here. Okay, mostly mostly in the non-dominant side, right side. Okay, but it can be bilateral. And then the where is going up here, is going above. Okay, the where pathway. So it's integrate. I showed you just now it's the integration area because visual input is a primary. The secondary is your integration, and then is going to the frontal lobe for analysis, for judgment, planning with that object. So, but what I'm trying to say here, so you have two, what and where. Same with the auditory here. You have auditory cortex here, so the what is going here. Okay, it's going down here, but the where is going up to here. So you hear the voice. So what voice is that? Is that from the birds or is that from the human? And where the voice? So it's going up to here, the integration area here. So the visual, auditory always have two. Even other somatosensory, they have two what and where. Okay, two pathway. This is a primary motor, so always arrange in order. So the limbs here and the face is very big here. Remember, the face much bigger here. So your eyes, your oral, your facial region is very big area here. Your hand middle, the leg is at the midline. Okay, if patient with a head injury injured this area, more midline lesions, and the patient have weakness of the leg than the face or the upper limbs, the hands. But most of the cases with head injury, most of the cases of the head injury, they injured here. Good injury, and opposite here is a contact coup. Unless somebody hit you from behind, for example, if you are in the bar or if you are in the social side, you have a fight with somebody, then normally they attack you from behind. So the coup here and contact coup here. But what we normally see in here in Malaysia, we see the head injury more. The trauma is more, then you see patient with disability affecting his or her prefrontal lobe. Okay, so what is the prefrontal lobe function? So the prefrontal lobe, you can see here, there are many functions, but again, they arrange in order. I'll show it later on. They arrange in order. The medial, lateral, below, and above. So the medial one is more like for limbic. Okay, the medial one. For limbic, and the lateral one for more like for motor. That's why you have Broca, spatial, more lateral. But here, more medial. You going medial is more for emotion, limbic. So that's principle you have to bear in mind. Okay. Again, from below and up, the arrangement for emotion and somatic is different. Okay. So they have this been arranged in systematic way. Okay. Even it's a mushy brain, but they are very systematic. Very organized. So we call it low entropy. In physics, if you learn physics somewhere with a behind physics background, so low entropy. Okay, high entropy is a chaotic dispersed energy. So you see the brain very interesting. Despite of having all the input from the universe, from the sensory, from the auditory, from the vision, all input, all sort of energy, the wave go inside the brain. Everything go inside the brain, but the brain should be high entropy, highly dispersed energy, highly disordered. But it's not. It's a low entropy. It's opposite what the scientists expected, and they're still mumbling, still try to figure out why. It's opposite. The features inside the brain is opposite. You expect A, but it turned out to be Z. Despite of high information go in, but the brain is having low entropy. That's very interesting. Okay, remember the Broca area? The Broca area, you probably should know this. Maybe come out in the some sort of exam, question MCQ or something like that. The speech area is a 44, 45. The visual 17, 18. So basically, it just give you probably MCQ question on it. No need to know detail, but maybe good if you can remember it. Even neurosurgeon cannot remember it. So go back to the anatomy. Brockman area again, same. Skip on that one, and then going now to the more limbic now. Limbic and more limbic and more limbic. So as I showed to you before, the one that below the corpus callosum, The one that below the corpus callosum is one of a few nuclei here, very important in limbic network. And those nuclei I said before are septal nuclei, and also this one here, nucleus accumbens. Many research, many intervention has been done on this area here, for drug addiction, for behavior disorder, for schizophrenia, okay, for depression. So this is the target for stimulation, deep brain stimulation. That means they give electric energy to this area, try to alter the network here. So hopefully by altering the network here, the other nodes, the other connection also will become altered. And because of that alteration, the patient will show better behavior or improve in his or her condition. Okay. So this is one of two nuclei that is showing here. This is hypothalamus here, and then remember this area here, also part of the limbic ventral tegmental area. So if you read the book, anatomy you need to read on your own, but you have to listen to my lecture first, and then after that you go and read the book. So that's what everybody do anyway in medicine, in medical school, whatever. So you come to the lecture, and then after that you follow with your color book for more readings. Okay, so the one that I got you is here is ventral tegmental area, very important to know. And the substantia nigra normally happens in Parkinson's disease. They have low dopamine, so this area here affected because of low dopamine neurotransmitter inside the brain. One of the neurotransmitters, so the patient manifests himself or herself with a Parkinson-like disease, with a tremors, rigidity, slow in initiation of movement, lack of facial expression. It's a Parkinson. Okay. Can you hear me? I just wonder, am I talking to myself? Hello?
We can hear you, doctor.
Yes. Okay.
Loud and clear.
Okay, so now we're looking here at the picture here. This diagram, I mean, you can get it from everywhere, Google and so on, but they are very interesting. If you read the book, sometimes you need to have the computer next to you so that you can click or you can Google it immediately. Okay, so nowadays I think it's not like my years before, but now you can Google it immediately. But as long as you have one reference book or more, then you have a computer next to you, then you can Google it where the structure is. So this looking into deeper or more defined, more clear. Clearer. So just now talking about those three important nuclei. Next, you can see this nuclei here. There are many nuclei inside here, but it's a gray matter here, amygdala. So amygdala is very important structure of the limbic network, limbic system. And then next to the amygdala, you have hippocampus here. The drawing is not as should be bigger. The drawing should be bigger. This one too small. So the hippocampus lying here, and the parahippocampal gyrus. If you read the book, the parahippocampal gyrus is below it. Okay, it is such like a second layer. So this is the first layer, the primer. This is a secondary. So the primer of the network, this one, so amygdala, hippocampus, but the secondary network is a parahippocampal gyrus below it. Okay, so because it's connected with the cingulate cortex, cingulate gyrus, but this one, the primer one, it connect with other deep nuclei. The amygdala, hippocampus, you see the network here. This is a white matter thread. Okay, this is the phonic. So like some surgeon doctor doing the surgery, if get injured, the phonic get injured, then after the surgery, patient have altered memory. Okay, change in memory, especially if both sides affected. So remember, they have always two, amygdala right and left. Phonic also have right and left. Okay, hippocampus also right and left, dominant and non-dominant side. So hippocampus and also communicate with the structure through the phonic, go to the memory body. So where is the memory body? I showed it before. It's at the level of the third ventricle, the floor of the third ventricle, so below the hypothalamus. Okay, and then it has connection with the thalamus. So if you can imagine, here is the thalamus. Okay, below here is a hypothalamus. Here is the thalamus. So it has connection with the hypothalamus. Okay, so this is hypothalamus, and behind here thalamus. Okay. So you see the phonic is divided into columns, column phonic, medial and lateral column. Why it divide? Because you want to go to different nuclei. So this one going to the memory body, this one going to the other nuclei at midline, septal nuclei, and other nuclei here. Okay. So this is the hypothalamus, the thalamus, amygdala, the hippocampus. Okay. So some doctors remove the hippocampus because patient have epilepsy. So some epilepsy, the problem arising from the hippocampus becomes sclerotic or pathological, or they are becoming atrophic, small. So because of that, it give rise to epilepsy. So the doctor have to remove this. Okay. So very close, amygdala and hippocampus. You see this another example here, the connection, the phonic, with a deep structure. So if the lesion here, you see the red color dot, the lesion, like for example here, this MRI of one of the patient in USM, there's a lesion here. So what this patient have is episodes of deja vu, abnormal sensation, difficulty to understand, difficulty in producing speech, with periods of confusion, inattention, disorientation, associated with a memory disturbance. So it is sort of like limbic manifestation. So why limbic? You see the structure here, but you thought it's away from the limbic, but in fact, around this area here, around the dot here, you see the phonic. So that's why you have to appreciate the phonic here, the column of phonic. Okay.
Professor, may I ask you one question?
Yeah.
When we move the hippocampus, is any side effects for the patient?
Yes, it depends. If the hippocampus, you remove the hippocampus on the dominant side, then the patient might have memory disturbance. If you remove it, the patient might have language disturbance as well, because difficulty to retrieve the memory or the words. We remove it basically because the hippocampus is not working well anymore. So normally, before we remove it, we check whether the memory on the opposite side is good enough or not. Because of the disease, the neuroplasticity happened that it shifted to the opposite side. The memory now becoming more active in the opposite side. You are right. Some patient, if you remove the hippocampus, he or she might have memory disturbance. So that's why we have to screen. We have to do more investigation prior to before remove the hippocampus, and then we discuss with the patient the good side of it and the bad side of it.
Okay. Thank you.
Yeah.
And Professor,
Yeah.
how do we investigate whether if the non-dominant side of hippocampus has good memory?
Talking about the hippocampus memory first, you want to know whether it's a dominant or non-dominant for language or memory. So, the test is a psychological test or the scoring system. One, non-invasive. You ask the patient, you interact. There's a questionnaire, or I think your colleague know it. Your lecturer, Dr. Faiz. So there's a Welsh test. I can remember something to this. All these questionnaire batteries for memory. Okay. So if the lesion is on the left side, for example, and then you do the test, it's impact. So the score is tally with the lesion. So something to do with a calculation, the number of score, and then you can say it's a left side or right side. Okay. And the second one, you can do a functional MRI. Functional MRI looking for the language. So ask the patient to do the language test during the functional MRI. During the bold signal, BOLD, bold signal. And also you have a test for the memories, and you can do this during the functional MRI. And of course, you can do other imaging like PET scan, positron emission tomography, PET scan, and you can do it with brainwave, like MEG, magnetoencephalography. Okay. But at the end of the day, you always discuss with the patient. All this investigation is not 100%. Okay. Okay. So
Prof.
yeah.
Prof,
Yes.
for example, with those who have epilepsy, adakah semua diorang akan diselect untuk buat operation keluarkan hippocampus?
No, not all. We normally remove the one with the refractory to medication. That means the medication is not good to the patient anymore. So it's a last resort. Severe cases.
Okay, thank you, Doctor.
Yeah. Okay. This I think again just a recap. Show you where's the hippocampus, where's the amygdala. Nut-like structure is a nut-like. The hippocampus is a seahorse-like structure. So this again the picture shows the orbital, the inferior part from below. You can see from below. Okay. And the structure here, you come across the word entorhinal cortex. This entorhinal cortex, perirenal cortex, they are below, below and near the parahippocampal gyrus. So this is another cortex, very important cortex, entorhinal and perirenal cortex, which is associated with the hippocampus. Okay, so if you come across reading, so this is part of the limbic as well. It has connection with the hippocampus. So this diagram shows deeper view, the hippocampus, amygdala, and this the one that I showed just now is a nucleus accumbens. So some people call it nucleus accumbens as part of the VS. VS is the ventral striatum. Okay, ventral that means below. The striatum is this one, the globus pallidus putamen caudate nucleus. Okay, so below the striatum, this structure, the blue one. So ventral is below. So this ventral striatum. So it consists of nucleus accumbens and some other small nuclei. Okay. So if you read the book, don't get confused. Some book use it ventral striatum. Some mention nucleus accumbens. Okay. Nucleus accumbens is more precise, more detailed. Talking about one nuclei. Okay. If the whole group is a ventral striatum, so you have many more nuclei or area or connectivity. And you can see now here the medial one. Okay, remember? I'm talking about the medial and the bottom. So most medial and most bottom to do with more like behavior, and the one that lateral is more like for motor, and above more like for motor. So this division, okay? Limbic, associative, motor. Limbic, associative, motor. So if you go deeper to the amygdala, I'll just recap for amygdala for the limbic system, okay? Remember, I think next week one of you is going to present the limbic again. So all of you should read about the limbic. Very important. So one of you should present to all of us on the limbic system. Have you allocate anybody to present it next lecture for my lecture? You all have it. Somebody to present it. 1 or 2 or 3 is up to you. You have you got any volunteers? So you can decide among yourself, right? Is that okay? Okay. So now look at the amygdala. Okay, the amygdala is part of the limbic. So as I said before, it has many nuclei, many connections. So the connection here, you see the arrow here is afferent and efferent. So this one going out, this one going in. So this is afferent, is efferent. So it's always dual. And here maybe just only one direction, but still debated whether they have connection. I think it's a dual as well. So the recent research and so on shows there's also come in as well. It's not just only one out. Same with this one. So you see the hypothalamus connection to do with endocrine hormone autonomic. So that's why if you have behavior changes, you have behavior disease, if you have mood disorders, sometimes you have this palpitation, autonomic disturbance, or maybe even collapse or syncope, they call it collapse, sudden collapse. You thought patient have something, but it's just something to do with a reaction with this network hypothalamus. Okay, so amygdala pathology or disease can affect the autonomic system, and amygdala pathology can affect the hormone system. The amygdala pathology can affect the breathing. the breathing pattern. So the patient might have breathing disorders as well. Might affect the cardiovascular system as well. See, so one small area affected, but it can cause many other areas also get affected. Such a massive, very massive network. So it's a brainstem here. Okay, the olfactory system is I think more important for talking about lower animal. Okay, rabbits, vertebrate, but lower animal. They have bigger system. They have bigger nose, bigger olfactory system compared to us. The hippocampal formation, okay, learning, memory, striatum. So what's consists of striatum? So I got a lecture here. Maybe you can get it from this my lecture PowerPoint, or you can read what consists of striatum. So you can divide further. Okay, you can see my slide later on. It's a basal this is a bad nucleus of stria terminalis. Bad nucleus of stria terminalis is near the septal area, septal nuclei. Bad nucleus of stria terminalis is BNST. It's around the septal nuclei region, in front of the lamina terminalis, in front of the third ventricle, in front of the hypothalamus. Okay. Basal forebrain is nearly close to this area here, and the thalamus. Okay. So if you have lesion amygdala, it can involve many other areas, the thalamus, even the BNST. So it can cause anxiety and even lack of motivation in that disorder. So that's why you see schizophrenia have many manifestations, not just only one or two, but have many because of this connectivity. So you go deeper. This is a connectivity. You can study on your own. It's in the same slide. So this is the amygdala, and people do more research and find out the amygdala. Maybe not just only one area here, not just only one nuclei here. So the amygdala should include this nuclei as well. So they call it extended amygdala. So in certain books, they're talking about extended amygdala. Extended amygdala nuclei. That means the amygdala has some sort of connectivity, or these three nuclei can be regarded as one amygdala. Okay. So what are those nuclei? It's the central nucleus of amygdala, of course. All the nuclei inside there. You have basolateral nuclei, you have medial nuclei, central nuclei, all these nuclei. And this one, as I said just now, it's a BNST. Bad nucleus of the stria terminalis. Okay, if you're going medial toward the midline, so you can see here, this is a small nuclei. I show it later on the other imaging. So this is a nucleus accumbens here. Nucleus accumbens, if you go more medial, near the midline, so as I said, it's below the striatum. We call it ventral striatum. So inside the ventral striatum, you have nucleus accumbens. So now people call it all these three as extended amygdala. Okay, don't get confused with the terms. Okay. Here are the MRI features, the MRI of the brain. So just now we'll look at the anatomy. So where are those structures? So, I show you more MRI later on. I have many slides with me. So you have anything after my lecture? You have another lecture? Do you have another lecture after me?
Yes, we have two more.
Two more, I see. What time should I finish? 2 o'clock, 3
Yeah, 2.
2 o'clock.
Yeah.
Okay. So looking here, the MRI, you see this is the cross section. That means the axial view. So MRI always have axial and have sagittal cross section, and this is sagittal. And the one is the coronal. I don't show it here, but here you see the axial view. The midline is the brainstem. You see, always remember the midline brainstem here, and the front is the frontal lobe, and lateral here is the temporal lobe, and behind here is the occipital lobe, the vision. If you go up, maybe up here, you can see the parietal lobe, but you cannot see it on this slide. You see the amygdala is at the front here, behind is the hippocampus. Same as the opposite side, it's the left side. It's the right and it's the left. So this amygdala is the hippocampus. So maybe the left side is abnormal compared to the right, smaller on in the left side. This is sagittal view, the amygdala here, the hippocampus here. Okay. So why you have this 3 slide? Because you can appreciate the structure in 3D. Okay. You should study in 3D. You should study in all slices. Then you can appreciate the 3D of the nuclei. Okay, of the anatomy. So you should study all. But certain slice, certain view best define certain area. So for example, amygdala and hippocampus best to see on the axial view, this view, and also the coronal view. But it's not good to see on the sagittal view. Okay, so you must take that point. So some structure best see on the coronal view. For example, if you want to see the optic chiasma, the optic nerve cross, best see on the coronal view, but less so in the sagittal view. Okay, best on the corona and second best on the axial. So you must appreciate that point. Now, hippocampus. Hippocampus. You see, there's a many small nuclei or area. Call it CA1, CA2, CA3, and CA4. So many researchers have done many research on these aspects on the CA1, CA2, CA3. So it's a very complicated structures. Physiology, especially physiologists, they do all sorts of monitoring and recording, electrical recording. So the wave here is a very active wave. It's not like alpha, delta, theta, beta. It's above it, above the beta. So gamma, hypergamma, epsilon wave, but very hyperactive. So the deep nuclei, they have very active wave compared to the cortex. Okay. So this is the dentate gyrus. You come across the dentate gyrus in the hippocampus. It's a fimbria and it's a dentate gyrus. This is a coronal view. If you can appreciate, it's a coronal view. Okay. You can imagine here. This is a brainstem. It's a coronal cut, like this MRI here. You see the MRI here is a coronal cut. This area here corresponds to this area. So when you cut like this on the MRI, then you can see here is the hippocampus here. You can see here the thalamus here. You can see here part of the pons. You can see here the cerebral peduncle, where the thread is going up to the cortex. This is a corticospinal tract or pyramidal tract. This is insular cortex. This is a part of the temporal lobe. So this is hippocampus. So if you enlarge this area by drawing, by this drawing, here you can see the drawing here. It's a coronal cut. Okay. So one slice. If you cut more slice, you can see more. So the image should appear tapering once you go behind. If you go forward to the front, then the image, the hippocampus should become bigger, and then at the end you can see the amygdala.
Prof.
Yeah.
The previous slide, CA1, CA2. What is it means by this?
It's an area of the hippocampus to do with different neurons. CA1 have more pyramidal neurons, CA2 have more different neurons, and the electrical wave or energy is different. So they have different function as well. So they have different connectivity.
Okay,
That one very detailed. It's a PhD level. You have to do it. So. Okay. Now. You know the area: amygdala, hippocampus, nucleus accumbens, septal nuclei, cingulate cortex, the brainstem, and then you come across in your reading maybe the pathway, the white matter tract, the highway connect between A and B, the highway that connect between A nuclei and B nuclei, the highway that connect between A nodes and B nodes. Basically, it's the same thing: nuclei, nodes, gray matter. Okay, so this is the highway. This is a white matter tract, okay, or pathway. So mesocortical pathway, mesolimbic pathway, nigrostriatal pathway. So they refer to the nigrous substantia nigra connect to the striatum. This a mesolimbic limbic area connect with the mesial. Mesial, that means part of the limbic. Mesocortex, part of the limbic. Mesial is part of the limbic. It can be amygdala, can be hippocampus, connect to the cortex. Okay, mesocortex, mesolimbic. It's a name. Just only know that you have to remember by heart. These are networks. Again, show the networks or of those, and you have the gray matter, the nuclei, and then you have white matter tract or the highway. Okay, so this, for example, the frontal cerebella. The frontal lobe connects with the cerebellum. The blue ones, the reward network. So it's involved the, see here, the nucleus accumbens, the red one. Nucleus accumbens play big role here. And then beside the thalamus and also the basal ganglia, but you see the nucleus accumbens, part of the limbic system. Which I think why nucleus accumbens so prominent. I think I think the researchers or the manuscript, the publication done mostly on this nucleus accumbens. So some other nuclei, not to say they are not important, they're probably more important than nucleus accumbens, but I think because of the study are lacking in that nuclei, so that's why people not talking about it much yet. Okay. For example, recently the paper came out on habenular nucleus. Habenular nucleus is part of the limbic. So habenular nucleus taught as one of the important nuclei for schizophrenia as well. I'll show you later on where is the habenular nucleus. Okay. So as I said before, you can roughly or generally divide the network in the limbic or in the brain basically as very coordinated and very systematic brain with the limbic, with the associative and with the sensory and motor. So you have this special arrangement. Okay. Again shows deeper view, nucleus accumbens, ventral. See, ventral pallidum, ventral striatum is different. Ventral pallidum is more lateral. Pallidum, globus pallidum is more lateral. So another one is a ventral striatum. It's more medial. Okay, don't get confused with those two. Ventral, that means below for the cerebrum. Pallidum and striatum different. Huh? This probably you need to appreciate this this view here, the 3D view, the globus pallidus. The globus pallidus, and the thalamus, and the caudate nucleus. Okay, C shape like. So you can see like a lot of the ring-like structure. You know, this one same. It's a lot of the ring-like. It's a ring-like. So if you study the architecture of it, this is an infinity shape. Hippocampus is a seahorse, is the infinity shape. This one is a spiral, like you call it dura. Dura shape is an infinity shape. D-U-R-E-R, dura shape. So this one is a deeper 3D, more like 3D view. Now you can appreciate how it's connected, right? So this is the amygdala. Okay, this is a BNST. You can say it's a BNST here. It's a nucleus accumbens here. This is extended amygdala. So how does it communicate? It's an anterior commissure here. Anterior commissure that we know. Maybe some other small tract that we haven't know yet. This anterior commissure communicate between amygdala to the midline structure. And I show it. There's some small nuclear tract connect to the medial structure as well. Not just only anterior commissure. There's there's some other tract as well. But you can see the 3D here, the shape of the caudate. It's a C shape like. Okay. And this is the globus pallidus. You have globus pallidus external and globus pallidus internal. Okay. So divide into two. This internal inside, this one external outside. And the more external you go beyond the globus pallidus, you can see this one, the lentiform nucleus. Lentiform nucleus is consists of putamen, lentiform nucleus, putamen, and globus pallidus. Okay, so putamen here. This is a putamen. So this is the term: lentiform nucleus, putamen, and globus pallidus. This is a putamen here. Okay. So where is the ventral pallidum? Ventral pallidum, the one I showed here just now, is a ventral pallidum. It's small area below here, below the pallidum. It's a pallidus is a globus pallidus. So they refer to below the globus pallidus, below here. Okay. So the area below the striatum is below the whole structure here. Below here, it's a nucleus accumbens, ventral striatum. And probably you can appreciate now. Here's a substantia nigra in the brainstem. I mentioned just now the Parkinson area, substantia nigra in the brainstem, the midbrain. Inside the midbrain, you can see the red nucleus as well. So they remove everything, just show the red nucleus. And above, you can see the subthalamic nucleus. Why sub? That means below. Sub is a below. So this nucleus lie below the thalamus. So if you can imagine, there's a thalamus here. The thalamus has been removed, so you cannot see the thalamus. So you can see the subthalamic nucleus here. So sometimes in Parkinson, we stimulate this nucleus to make the patient improve. So the subthalamic nucleus here. It's a part of the caudate nucleus, the C-shaped like structure on this side. You can view on the opposite side. This one, they just remove the body, just only the tail here. Okay, so if you can imagine, this is the opposite side. This is on the ipsilateral side. This is on the right, on the left side. This is on the right side of the brain. The face here, the face, the nose is the eye. There's a nose here. It's a behind. So this is the right side. This is the right side. This is the left side. Okay. If you can imagine, can you imagine this diagram? It's the right side, right hemisphere. This one inside the left hemisphere. The midline here, around the substantia nigra here. This is a midline. If you can imagine the thalamus here, the hypothalamus should be around here. The hypothalamus here, the thalamus here. Okay. So you see the connection, the connectivity, very, very obvious here between the globus, between the basal ganglia, whole thing called basal ganglia, with the limbic structure, amygdala hippocampus. So that's why they have connection. Mesial striatal pathway, you call it mesial, hippocampus, amygdala, striatal, striatum, globus pallidus. So this pathway called mesostriatal pathway. Mesostriatum. Okay. So this again show the picture amygdala, caudate nucleus. It's the outermost, the putamen. Okay, the outermost is the putamen. If you go deeper, if you remove the putamen, you go more medially inside, you see the globus pallidus externus. If you go deeper, you see the globus pallidus interna. Okay, if you're coming from below it, you see below the pallidum is ventral pallidum. If you go more medial, but still below the striatum, you can see the ventral striatum. Inside it is a nucleus accumbens. Okay, so roughly around here, below the caudate nucleus and the medial part of the globus pallidus internus, nucleus accumbens. So probably you can read on your own. This is I produced a book in neurosurgery, but this is a slide that I get from that book. So it summarized the whole thing, talking about what is lentiform nucleus. The lentiform nucleus or lenticular nucleus comprise the putamen and the globus pallidus. Okay. Remember this one? Lentiform nucleus consider putamen and globus pallidus. That's the lentiform nucleus. And then you read the book somewhere, and the term come out is a pallidum. What is pallidum? So pallidum consists of a large structure called the globus pallidus, together with a smaller ventral extension called the ventral pallidum. Okay. So globus pallidus plus ventral pallidum, the structure below the pallidus, is called pallidum. Okay. So I summarize the whole thing for you now, easy for you. So you get this and then try to understand. If you read the book, then you come across these terms, then it's not confusing for you at all. Okay? So globus pallidus got GPI and GPE, external and internal. Okay? And both segments contain primarily GABAergic neurons, and mostly inhibitory because of GABAergic. And then you might come across the word ventral pallidum. So ventral pallidum, you say pallidum consists of globus pallidus and ventral pallidum. So ventral pallidum, the one that I showed you before. Structure within the basal ganglia of the brain is an output nucleus, project to thalamic nuclei. Okay, it's below the pallidum. is a core component of reward system, which form part of a limbic loop of the basal ganglia. So it's regulate management, behavior, emotion, and so on. So that's the ventral pallidum, below the pallidum. Contains one of the brain's pleasure center, which mediates subject's perception of pleasure that result from consuming certain rewarding stimuli. Okay. They have small subcortical nuclei inside the ventral pallidum. Okay. Role in addiction for ventral pallidum. So ventral pallidum also play a role in addiction. Okay, I show it maybe the picture after this. Okay, this is a thalamus. This ventral striatum. This is a dorsal striatum. Okay, this is a ventral pallidum, and this is a dorsal pallidum. Okay, you always have two, ventral, dorsal. Okay. Is there anything? Okay, here. Maybe I missed this one. Have a look here. The basal ganglia. Talking about the basal ganglia. A group of subcortical nuclei of very origin in brain vertebrate, including human. The main component of the basal ganglia, as defined functionally as the striatum. So you have both dorsal striatum, caudate nucleus, and putamen. You call it dorsal striatum, and ventral striatum, nucleus accumbens, and olfactory tubercle. So basically, the striatum consists of caudate, putamen, and nucleus accumbens. Okay. So if we go back to the picture here, so this is the caudate nucleus, is the putamen. So caudate, where's the caudate here? This caudate nucleus, and the putamen, you call it striatum. Okay, caudate, putamen, striatum. And the putamen plus the globus pallidus, you call it lentiform nucleus. Okay, so caudate plus putamen called striatum. So remember here, so striatum, caudate nucleus, putamen, and all this nucleus accumbens. So all this called striatum. The striatum divide further into ventral striatum and dorsal striatum. So there's dorsal striatum, caudate nucleus, and putamen, and the ventral striatum is nucleus accumbens of olfactory tubercle. It's a nucleus accumbens. Okay, understand that? So in the book, you come across the word striatum, consists all this structure here: caudate, putamen, and nucleus accumbens of olfactory tubercle. The striatum. Okay, and the lentiform nucleus, that one, and the pallidum, that one. So now, first you have to get clear with the terms, with the meaning of the terms. Otherwise, you're confused reading the book. Okay, the picture. Okay, here now you remember. So the ventral striatum and dorsal striatum. What consists of striatum? So the caudate nucleus and the putamen. The putamen plus the globus pallidus, you call it lentiform nucleus. So in most of the book, they don't use lentiform nucleus. They don't like use lentiform nucleus. So most of the book you come across the pallidum or pallidus and striatum. So you should probably remember what is striatum, what is pallidum. Okay, hardly they use lentiform nucleus. If there is one, then you should know what is lentiform nucleus. Okay, so ventral striatum, ventral pallidum, more like below them, and dorsal, the bigger one, the bigger structure one. The one that you can see most, you can see obvious. Okay, the dorsal one. And you see the arrangement very, very systematic. The looping, the loop, the law of the ring. So because of that shape, the brain shape, then the ring is not being cut. The ring is well formed ring. Inner ring, outer ring. Okay, for the limbic, emotion, mood, associative, sensory, and motor. Probably you can appreciate here is the ring. It's a law of the ring. The inner ring and the outer ring. Okay. So very systematic. So you have a ring here, you have another ring here, you have another ring here. So what is this? This one is a codec. This one part of they show it, the globus pallidus, the striatum. This is the striatum is the caudate nucleus and the putamen. Okay. This part of the cortex, cerebral cortex. Maybe the prefrontal lobe here. Maybe here part of the cingulate cortex. Okay. This is a thalamus. What is this? A globus pallidus. It's a substantia nigra. So this diagram show four main areas: thalamus, globus pallidus, or substantia nigra, part of the brainstem, and the striatum. The striatum is the caudate nucleus and the lentiform and the putamen. And this is the prefrontal lobe and the cingulate cortex, or prefrontal, the cortical part. What I'm trying to say is a ring here, all four rings. So here, again, show the same slide as before. Now you can appreciate what I mean by ring. This diagram show, again, the one I explained to you about the response. You have hormonal response, autonomic response. Okay. This shows the hippocampus, amygdala communicate with the hypothalamus, and because of the hypothalamus, it communicates with the pituitary gland. So pituitary gland will secrete all this hormone, cortical hormone, cortisol, growth hormone. So they interact with the adrenal gland inside the body above the kidney. And this also, the hypothalamus and pituitary also influence the immune status of the body, the immune system. Okay, very complex. So probably if you have disease or schizophrenia, psychosis, probably sort of immune instability as well. So maybe the patient or that person has some sort of immune disorder as well. That means his or her immune is not like healthy person. So key regions implicated in mood disorders. So you can summarize now. What are those regions? Part of the limbic. Maybe more, but the study so far show this important area, but the future study will show more, will highlight more. As I said, the prefrontal lobe, okay, the prefrontal lobe, especially the medial and the base or the orbital one. And then the hippocampus amygdala, okay, and then the cingulate cortex. But here the dorsolateral prefrontal cortex, the dorsolateral one, some people also include important part for the limbic as well. It's not limbic, but it has communication with the limbic, the medial and orbitofrontal one. So some people include it, some people don't include it as part of the limbic. So now go to the schizophrenia, psychosis. Psychosis, schizophrenia, many theory behind it because we don't know what's going on, what is the etiology, the pathogenesis of it. So we still don't know, right? So all these hypotheses come up. First, investigation on the neurotransmitter. So what are the transmitter that involved? So one of them is a glutamate, another one is a dopamine. Okay. So still under debate. So schizophrenia or psychosis, you can see with the autism and epilepsy, some of the manifestation of psychosis is overlap with the epilepsy. Some of the manifestation. And from the genetic study, this is a genetic mapping, shows that some genetic overlap between these two disorders, or even with epilepsy and autism. Okay, this one has been clinically proven. There's a connection between autism, schizophrenia, autism, epilepsy, schizophrenia. Okay, to show you that the brain network involved in these three pathology, they are very close enough. Okay, this diagram show again the limbic. Yeah, can skip that one. Beside the talking about the the dopamine glutamate, but you can see more study now focus more on neuroimaging for this disorder, schizophrenia. So the neuroimaging nowadays focus on functional MRI and connectivity. So what happened in schizophrenia? They found that the disruption in connectivity between structure A and structure B, between structure C and structure D. So okay, so in autism you can see some networks are overactive and other network underactive. Okay, so this network study very confusing sometimes because A study show A study show this network, another study show another network, but from the meta-analysis, that means they combine all the studies. They conclude that certain networks are very important, especially the one that connect between the amygdala, hippocampus, and nucleus accumbens. Okay. You can see here the temporal lobe different in temporal lobe between the control and schizophrenia. This is a normal healthy person, but in schizophrenia have hyperactivity or different signal in the striatum. Okay, compared with the healthy normal person. So this sort of function MRI imaging or brainwave imaging. So just now talking about the neurotransmitter. So probably we go some recap or we try to revise a bit on this neurotransmitter. So you have dopamine and serotonin pathway. So the blue one is the dopamine. As I said, dopamine mostly in substantia nigra, important in Parkinsonism. So it's close to the basal ganglia striatum. So that's why patient with Parkinson, you have basal ganglia disorders, or the doctor stimulate the basal ganglia to get the patient improve, or they stimulate the subthalamic nucleus because it's a connection with the striatum. So this is the dopamine pathway. And see the dopamine also project to the frontal lobe. And interestingly, this is a serotonin pathway. So serotonin pathway is going here even behind the whole brain, but it's play a big role in sleep, in sleeping, memory, mood. You see the sleep one. If you have altered sleep, then your mood is not normal. So that probably the pathway, the neurotransmitter that affected is the serotonin one. Okay. So people say about dopamine. So dopamine actually can give rise to other neurotransmitters. So from this metabolic pathway, you can appreciate how they are interact. Dopamine can also give rise to noradrenaline, and from the noradrenaline is give rise to adrenaline. And this one, the tryptophan group, give rise to the serotonin. Okay, so this called monoamine neurotransmitter group. So you have serotonin, dopamine, noradrenaline, adrenaline. So you come across a lot in the brain. Or even tryptophan nowadays, or tyrosine. They're talking about they talk about the neurotransmitter inside the brain, covering even the tryptophan and tyrosine. So dopamine pathway in schizophrenia. Why dopamine? Because patient with a Parkinson, they lack dopamine. Then once they give dopamine to the patient with a Parkinson, the patient might have side effect from this dopamine overload or excessive dopamine prescription. So the patient manifests schizo or psychotic like. Okay, so that's why the hypothesis behind it is a dopamine neurotransmitter is involved in these disorders. So where's the dopamine? As I said, the striatum, the substantia nigra, hypothalamus, and this the limbic cortex, the dorsolateral, the ventromedial. So the dorsolateral one, some people include in the limbic part as well. Okay, this what's this? Dopamine. same. Talking about the dopamine. Okay, dopamine theory. Just now talking about the monoamines, and now you see the different other neurotransmitter amino acids, acetylcholine and catecholamines. Catecholamines are the monoamine, but here I show you two more amino acid group. You have glutamate and GABA. Okay, this inhibitory normally, so this one stimulatory normally. It's acetylcholine. You have acetyl-CoA and choline give rise to acetylcholine, and the serotonin group you have the serotonin, and this one the noradrenaline. So this slide cover all. Show all the neurotransmitters: acetylcholine, GABA, glutamate, serotonin, and also dopamine, noradrenaline, adrenaline. So this neurotransmitter inside your brain. So this the picture show where they are: the dopamine, the acetylcholine, the nuclei that play important role for acetylcholine transmission is this one: the nucleus basalis and septal nuclei. Okay, septal nuclei and nucleus basalis. And this one, the pontum mesencephaly, is a part of the brainstem. So nucleus basalis and septal nuclei. No adrenaline, locus coeruleus, okay, in the brainstem, project to the thalamus and part of the hypothalamus. So this adrenaline system gives rise to the autonomic heart rate, palpitation, bradycardia, increased heart rate, lowering the heart rate. Okay, fight, flight, fight, flight, and fear system. It's a serotonin pathway. So the nuclei that mainly it was the Raphe nuclei in the brainstem. So locus coeruleus, no adrenaline, Raphe, serotonin, nucleus basalis, septal nuclei, mainly acetylcholine, ventral tegmental area, substantia nigra, mainly dopamine. So this come up maybe in MCQ. Okay, psychosis, schizophrenia is you probably can divide into two, positive and negative symptoms. So probably you can skip on this, go to the symptomatology. So you have positive symptom and negative symptoms. So this is the division of the symptoms. Okay, so what are those positive symptoms and what are those negative symptoms? So a patient with psychosis or schizophrenia, they have positive like symptom. This one, delusion, firmly held erroneous belief. So delusion. Okay, you can see something flying from the sky down to the earth, or for example, Mr. A coming from planet Pluto down to Earth. It's a delusion. There's no stimuli, but patient sees something there. If there's a stimuli, but patient misinterpret it, we call it hallucination. Okay, distortion or exaggeration of perception in any of the sense. So, but there's a stimuli there. So misinterpretation of the stimuli. So the stimuli is music, but patient interpret as ghost. So that's hallucination. Disorganized speech, thinking, part of the positive symptoms. Grossly disorganized behavior, bizarre behavior. Okay, social disinhibition. This grossly disorganized behavior. But by my patient with a brain tumor in the prefrontal lobe also can have this manifestation. One patient came to the emergency department naked, not wearing anything. So the doctor thought of something else, but it turned out to be big tumor in the frontal lobe. So patient has a lack of social inhibition. Okay. So the catatonic behavior can happen. This normally you see in the movies. What you call it? That movie, the ghost movie, or the Omen movie. So catatonic epilepsy, like. Psychosis can also have catatonic like behavior, rigid or bizarre postures. The bending posture, the neck bending to the opposite side, or even bending behind. The catatonic like posture. The negative one, you have emotional expression, lack of facial expression, voice tone is low, lack of body language, okay, poverty of speech, call it alogia, reduction difficulty in inability to initiate or persist in goal-directed behavior, no motivations, the evolution. Okay, you all with me? Hello? Hello?
Yes, we are with you.
Okay.
Yes, Prof.
Okay, so this one the PANSS. If you do study on the schizophrenia, this is the scoring system that they use to grade to grade the severity of the schizophrenia that the patient have. So this is called PANSS scoring system.
Prof.
Yeah.
This assessment can use for those who have only psychosis.
This one was they refer for schizophrenia.
So it's not valid if we. So this assessment not valid if we use to the patient that have only psychosis.
Psychosis is a broad term. Under the umbrella of psychosis is schizophrenia. Okay. So once you have psychosis, you should diagnose it whether it's a drug-induced psychosis or is it schizophrenia. So you have to have a proper diagnosis. But this scoring system apply for schizophrenia score. You see the schizophrenia score for psychosis related to other pathology. I'm not sure. You ask the psychiatric whether can use for none other diseases or not. But I know this one is used for schizophrenia. Okay. But psychosis is a broad term. Under the umbrella of psychosis is schizophrenia. Okay.
Thank you, Prof.
So this the again talking about the transmitter just now, and now people talking about the genetic. So they studied the genetic of it. So they found out there's a genetic element of the schizophrenia as well. They did a study on the twin who have schizophrenia. They found out it's a connection. And this is a dopamine hypothesis I mentioned to you already. Patient with a Parkinson given dopamine, then side effect is the psychosis like schizophrenia like. So it suggests dopamine is involved. Dopamine hypothesis. Okay, shows the proven based on imaging as well. The dopamine imaging, the PETs can use the dopamine. They show the dopamine is higher in the striatum. Patient without schizophrenia with schizophrenia. So something to do with dopamine. Okay, higher. Patient with schizophrenia.
Sorry, Professor.
Yeah.
Can we say that the schizophrenia is not genetic? Is very much connected with dopamine hypothesis? If the higher or lower?
The study show the study are divided. Some patients they are genetically related. Some study shows they are not genetically related. So under schizophrenia itself, the spectrum you can divide more in the future based on genetic and based on dopamine and based on blah blah blah. So I think the schizophrenia itself is a big term. So some patients have etiology based on genetic. Some do not related to the genetic, but to do with something else. Maybe maybe you see the neurotransmitter itself is abnormal. Whether it's correlate with the genetic, not sure. The study is still going on. Whether it's coming from one origin, not sure. Whether it's a genetic, is the whole thing, we still don't know.
Is that this dopamine hypothesis can be when it does higher? Is that can also affect it even is if we say if not genetic?
Yes. Even though it's high, it's not genetic. Yes, that's right.
Okay, thank you.
Yeah. Okay, another finding, the research done on schizophrenia, they found out the brain itself is abnormal, the anatomy of the brain. They look at the brain, the MRI of the brain with a schizo and non-schizo. They found out the schizo one is atrophic brain. Okay, so atrophic brain here, you can see the MRI here. It's the right side is a patient with schizophrenia. The ventricle or the CSF containing fluid is bigger compared to the normal brain, healthy person here. So the hypothesis behind it is again saying that something going on inside the brain, whether it's a dopamine or whether it's beyond the dopamine, the pathway or whatever, or anatomy itself is distorted. So it's still under investigation. But the point is, one is a genetic involved. Not all, maybe some. Dopamine, not all, maybe some. And this one, the brain anatomy one. But in conclusion, they highlight these are the three important points. So might be one patient have all, might maybe one patient have 2 out of 3, something like that. Okay, but it's not conclusive yet. So this brain damage to do with schizophrenia. This is another study done a long time ago with the head injury, and then they found out patients with a head injury tend to have schizophrenia after years and years of brain damage. So again, study done, but just show the correlation or relationship. Another study shows the neuroinflammation. Remember just now I showed you the hormones and also the immune system that related to the hippocampus, to the hypothalamus and the pituitary gland. Okay, so the hypothesis now also looking at the neuroinflammation. Maybe there's some sort of virus or maybe some sort of small body, small foreign bodies goes inside the human body, and these foreign bodies or virus or whatever you call it stimulate the body inflammatory system. The body inflammatory system seems to be exaggerated in the brain, so they call it neuroinflammation. Because of that neuroinflammation, you have all sort of brain damage because of the excessive overdrive of the inflammation in the brain. Okay, so this overactivity, for example, if you have virus goes inside, or you have foreign body goes inside your body or your brain, then this cell becoming activated like microglia cell, the T cell and B cell. So this B cell produce the antibodies. This Y shape is an antibody. Okay, the B cell, and the T cell is a lymphocyte. If you know about the blood cell inside the human, you have platelet, you have red blood cell, you have lymphocyte. Okay, and some other small nutrition and so on. So this T cell and B cell, they are lymphocyte. Okay, the lymphocyte normally they attack the foreign body or the enemy or anything that goes inside foreign to the blood or to the human body. So the T cell can attack direct the antigen. We call it the foreign body call it antigen sometimes. Okay, antigen. Medically we call it antigen. Can attack the antigen or can attack the virus or can attack the foreign body direct, or the T cell can stimulate the B cell, and the B cell produce the antibody coupling to the antigen or to the virus, and therefore they die. And this B cell and T cell, they actually activated by the microglia cell inside the brain. So this microglia play important role in defense, in inflammation for the brain. So you have astrocyte, you have microglia, you have glial cell, neuron and glial cell. So the glial cell, astrocyte. Beside astrocyte, you have oligodendrocyte, and you have microglia. This microglia more for defense, like. So for maybe the essay come out right on the defense or immune aspect of the brain. Maybe you can draw this picture here. You can just write briefly on this 3 cell. Okay, and probably you can talk a bit more about this interleukin IL is an interleukin. Okay, so this microglia produce the interleukin. This another thing that probably important for inflammation. So the interleukin, they have number, interleukin 1, interleukin 10, and sometimes they have no number. They call it TNF, tumor necrosis factor, alpha, interleukin alpha 1 beta. All this, they have pro-inflammatory or anti-inflammatory. So if this pro-inflammatory one increase, then you have excessive inflammation. Okay, so all this going up, and then brain might get injured because of that excessive inflammation. Okay, so if you have a question on it, probably you can talk about this slide. Okay. So in schizophrenia, you see the frontal lobe play a big role. That's why if you go to the psychiatric ward, they give medication, they give blah blah blah, what they call it, psychological rehabilitation and so on. But one thing most advanced center do, they stimulate the frontal lobe. Why? Because I said the prefrontal cortex play a big role. They connect with the limbic system. So the prefrontal cortex, dorsolateral, or the medial frontal or orbital frontal. So they stimulate with this structure here, call it TMS, transcranial magnetic stimulation. We do have here in dual dilemma. The navigated one is not working anymore, so it's under repair, it's expensive. But this one you can stimulate the cortex. Okay, so patient with severe schizophrenia, refractory or resistant to medication, so the psychiatrist might use this mode of treatment, call it TMS or transcranial magnetic stimulation, to stimulate the prefrontal cortex. Before, we used to call it transcranial electrical stimulation, TES, electric. But now the advance is a magnetic, transcranial magnetic. Electric and magnet always come together. You have electric current, you always have magnet. You have magnetic energy, you always have electric. So always come together. The electric one is the old machine. The electric one can be painful to the head, to the face, but the magnetic one is not painful. Okay. What's the unit usage? We call it Tesla for magnetic. For the electric, you see the voltage, you see the ampere. That one for electric. Where are we? Okay. The one that you stimulate here, the number, the lateral prefrontal cortex, is the one that you should stimulate for TMS. Why? If you stimulate here, I showed just now the connection to the midline, to the middle structure. You stimulate here the prefrontal cortex, then the wave, the energy, the electric, the magnetic energy will flow inwards and alter the network deeper. The nucleus accumbens, hypothalamus, and hopefully it will alter the network in the brainstem as well. And because of that, the patient can improve. So how much you give, what frequency, which mood, then you have to do the literature. The literature done on the animal. Normally they do on the animal first, and then from that you know the values, what frequency, how much frequency to give, and from then you modify on human. Okay, this example. Patient with auditory hallucination, they give TMS to the auditory area here, not in the frontal lobe anymore, but I give stimulation in the auditory cortex, because patient have auditory hallucination more than other thing. Okay, you see the application of the TMS. Yeah, I want to touch about this. The glutamate and GABA at CA1. Just now I show you the CA1 of the hippocampus. Remember, you have CA1, CA2, CA3, CA4. So the recent evidence, the recent study shows that the hippocampus amygdala play a role as well in the schizophrenia because of the GABA and the glutamate inside it. Where? In the hippocampus, in the CA1. So this is a CA1 area. This it's a cross-sectional, again, a cross-sectional, coronal. Okay. So this shows the CA1 and also the glutamate and GABA area. Okay. They are very complex here. But what I want to highlight here, this area also is the area that involved in epilepsy, and this area here also involved in Alzheimer's disease and probably in aging and in other mood disorder, aggressive behavior, patient with mood disorder, anxiety, criminal crimes. They have some sort of abnormality in this area. Okay, the study done in the animal shows that the amygdala, especially the basolateral part of the amygdala nuclei, play a role in the in this schizophrenia like. Okay, I can skip this one. This is the slide that I show the surgery done on one of the child, 9 years old, with aggressive behavior. Besides aggressive behavior, she also has epilepsy, chronic epilepsy. She has been suffering from epilepsy for I think 8 years. At the time she was 11 years. Oh no, she 10 years old, something like that. 10 or 11. So suffering from epilepsy for 7-8 years, and then last 3-4 years she developed mood disorders, aggressive behavior, autism-like behavior. So when we did the scan on this patient, we see the lesion in the hippocampus amygdala. See the white dot here? It's a calcification. It's a bone-like structure. So this shows that the amygdala hippocampus is crucially, solidly show that this area involved in behavior or mood disorders. We published in the Child Nervous System recently in the manuscript journal. Just recently published for this child. What we did, we resect, we disconnect the network. This the if somebody never seen the hippocampus, this is the hippocampus, the white one. If you can imagine, this temporal lobe here. This is the midline near the hypothalamus here. So the surgeon coming from the outer to the inner. So reach the hippocampus, and you see this one is a calcification here, the star dot light. This is your hippocampus, the white structure here. All the memory stored inside here before being distributed to other part of the brain for long-term memory. So normally it goes to here first for short-term memory. And for this child, when we resect, the hippocampus is appear abnormal here. Abnormal in constituency. Okay. This is the brainwave of that child. We did the EEG, shows the abnormal epileptic light. This, you see the kissing wave. We call it the kissing wave between a lip above and below. So it suggests something to do with a focus of epilepsy arising from this lip. Okay. And then when we analyze further for this patient, it shows that this is a before surgery, this is after surgery. Patient got improved after surgery. Patient has reduced much in epilepsy and also reduced much in behavior. This shows before surgery, this is after surgery. You see the brainwave, the red one is the delta, the yellow one is the theta, the green one is the alpha, the blue one is the beta, and the black is the gamma. If you can see, here there's no gamma. Okay. The lowest one is the delta theta, slow. We call it slow wave. Alpha, the regular wave. The beta, the higher wave. Okay. After surgery, they are nearly symmetrical, but before surgery, in one hemisphere is more delta wave. So it shows asymmetrical or disharmony between the right and left hemisphere. So the corpus callosum that connect between right and left hemisphere, the energy that pass through the corpus callosum, they are unequal. And because of that, the patient manifests himself or herself with also of this abnormal behavior. Okay, it shows that the energy right and left is different. This is that's the reason why I think the advanced center now they do the EEG. I don't know why people here don't like EEG, but when I was in Singapore, they started doing the EEG in all psychiatric patients. I think it's very worthwhile doing it. All EEGs in psychiatric patients, because you can see the patterns before intervention and after intervention, before counseling or after counseling, before medication and after medication, before surgery and after surgery. So you have baseline so that you can publish, you can report your data. Otherwise, it's difficult. Just by questionnaire is old style, old technique. So now the advanced one is the brainwave, is the EEG, the simplest one. The expensive is the MEG. We do have, but now machine kaput. Still don't know how to repair it. It's very expensive, 60 million. Probably need to buy the new one, so 60 million. Okay, you see the before and after surgery for this patient like mood disorder and brainwave. This is the right, this is the left, this is the nose. It's a nose, it's a nose. Okay. So you see the asymmetry between right and left. This is before surgery, this is after surgery. It's more like symmetry. The brain dynamics, the brain energy dynamic is becoming symmetrical after the intervention. But before intervention, you see, it's split brain. We call it split. Split brain in mood disorder. Maybe in some other disorder, they have different pattern. Not fully split, but maybe different patterns. Okay? This again shows the study that you can do with this patient or with other patients with mood disorder and so on. You do the MRI. In the MRI, you can have DTI, where you can calculate the tensor or the water content inside the MRI. This again show the before surgery, this is after surgery, becoming equalized after the surgery. Okay. It shows the area that we resect. You see the video, maybe I'll show it later on. Okay, what is mania and depression? So I go quickly. Basically, the core is the schizophrenia, the psychosis. Mania and depression is different category now. Okay. Some patients with a depression just only have depressed mood, and some patients with a more severe depression, they have both depression and mania. Okay, increasing mood, low mood and high mood. Okay, manic depression we call it. So mania basically is elevated mood. Okay, you learn more in future lecture. I think here I touch you more a bit on anatomy a bit. So mania is a bipolar disorder. It's a defining feature for bipolar disorder, mania and depression. So some people use the word only mania, so to refer to the manic depression, or mania and depression, or bipolar disorder. Some people just simply call it mania. Okay. And then mania is a very excessive, very gross. And then some patient cannot be suited to categorize under mania, so they put it under lower degree of it. They call it hypomania. For example, who are addicted to shopping, addicted to go to the certain area, so it's more like hypomania. Yeah. Depression, when the energy is going down. Okay, so they have different different definition, different category, different types, different manifestation. Weight loss, lack in interaction, pleasure, agitation, diminished ability to think or to concentrate. Okay. Maybe physiological effect as well. Patient might have because it's connected with the brainstem, so patient might have autonomic disturbance, dryness of the mouth. Area involved in the depression again, same limbic. So nucleus accumbens amygdala. So that's why all this has been categorized under mood disorder or mood network, because we have not yet able to define precisely where exactly the pathology is. So in gross terms, we can say it's a part of the limbic involved. And again, nucleus accumbens amygdala. Anterior cingulate cortex is the one that been done research a lot. The cingulate cortex, but the anterior most has been investigated most. Why? Because the animal study show that's the area to study in depression, and also because of the imaging done in depressive patient shows hypoactivity or hyperactivity in that area. So that's why the researchers focus in the area, because the imaging based on imaging and based on animal study. So this implicated in major depressive disorder, MDD. They call it, some people call it major depressive disorder. So anterocingulate cortex, amygdala, and even striatum, and insular cortex, prefrontal cortex, hippocampus. I not mentioned about the insular cortex in the limbic system. The insular cortex is hidden underneath the temporal lobe and frontal lobe and parietal lobe. Is inside. Is inside and then it's lie outside the lentiform, the putamen. Okay, it's outside the putamen. Remember just now, it's a chordic nucleus putamen, and outside the putamen, you see the insular cortex. Outside the putamen. If I can show you, probably you can appreciate this one. Not good. I can show you this one. Where is the insular cortex? Insular cortex is here. I go back. Where is the coronal view? No coronal view? Here. Where is the insular cortex on this MRI here? You can see here. This area, insular cortex. So if you go deeper, it's the putamen. Go deeper, globus pallidus. The linear, the gray matter here is the insular cortex. Okay. Okay. So nearly same substrate, same area. Just remember that same area. Hold on, I answer the phone first. Hello, yes. Lecture. Okay, you can see here. What here is a brain circuit, endocrine, hot symptoms. So basically, this slide shows the level of the study that people are doing now, the imaging study and the metabolism or hormone or transmitter level. This imaging study for depressed area, highlighted in depressed area, prefrontal cortex, midline structure here, the striatum, ventral striatum. Okay. This is a network study. This one done by the computer scientists. If any of you are expert in computer algorithm, then you can do the connectivity study. That means this represent the area, the node. If EEG is represent the electrode. This is electrode 1, electrode 2, electrode 3. Then you can see the connectivity with your algorithm.
Professor, can I ask you this slide, the female brain and the male brain, because when we studied that is more connection within the hemispheres, there is the within for the male brain and the less connection between. So is that can also affect the depression and or how it looks like?
Oh yeah, that one difference between male and female brain.
Yeah.
I don't know. If you ask me that connectivity, whether it's intrinsic for female, because depression occur in more female.
Okay.
So I'm not sure. I don't know. Yeah.
Because it's a lot of connections here between the hemispheres, so it's quite interesting to see.
Yeah. I don't know. Probably you do study on this. Compare between the depressive male patient with the depressive female patient.
Yeah.
Yeah. You compare that. Yeah.
Okay. Thank you.
Okay. This one you can skip. This is basically talking about network. It's advanced stuff. Okay. This one computer scientist or you need a colleague that expert in computering, and you can do this network study. Okay. I skipped that one. You know, this image is a DTI. This is MRI. It's a DTI image. DTI shows the white matter tracks. Okay, it's a corpus callosum, the red one. The blue one is the pyramidal tract or corticospinal tract. The green one is the anterior posterior tract or posterior anterior tract. The one I told you before. This one shows the study that done on depression. When they stimulate a certain area of the brain, the patient improve. But most of the study come up with only 60% improvement, or maybe less, 58% improvement. So even some patient get worse after that stimulation. So that's why I said this need more studies. The area that they stimulate with the electric energy, the anterior cingulate, the anterior cingulate cortex, the one that I mentioned, the anterior most of the cingulate gyrus, and they stimulate this area as well, the subcaudate, that means below the caudate, like ventral striatum area. Even they stimulate the anterior capsule, That means you have internal capsule, then you have posterior limb and anterior limb. So they stimulate the anterior limb of the internal capsule. The posterior limb to do with the corticospinal tract. The anterior limb more like limbic or mood tract. You know the internal capsule? The internal capsule lie next to the globus pallidus and caudate nucleus. Here I got picture here. So this internal capsule, the white one, is a boomerang or sea-like. It's the white one, boomerang-like. It's an internal capsule. So next to it is a globus pallidus internus, outer globus pallidus externus. You go more outer, you can see the putamen. You go outer, you can see the white matter tract. This is a white matter tract. You call it external capsule. And if you go more outside, you can see the small gray matter. And beyond it, you call it another white matter called extreme capsule. And the outermost is the insular cortex. Yeah. If you study this area here, very interesting also area here. So medial or deeper to the or inside to the insular cortex, you have extreme capsule, external capsule, and claustrum. The gray matter between the extreme capsule and external capsule is claustrum. claustrum, claustrum. And medial to the external capsule is putamen. This one is internal capsule. Okay, so this is the area that they stimulate, and the finding, the result is still not promising. Okay, jump to the anxiety and fear. So basically, anxiety, fear again involve the amygdala, mainly amygdala. How to classify them? You have many type of anxiety disorder, generalized anxiety disorder, specific phobia disorder, social anxiety disorder. You cannot go to the crowd to see the crowd. Separation anxiety disorder. You cannot separate from your parents. Agoraphobia. You cannot stay in one room, small room. Panic disorder. You cannot stay in crowded places or in any area, any stimuli. And then this is selective mutism. Some, especially school children, age, they becoming mute when they go to school. But when they go back to their house or their playground, they talk to other colleague, or their friends. But when they go to school, they have mutism, selective mutism. So I think you can read on your own all this definition and so on. But what I'm trying to say here is more classification. Post-traumatic stress disorder is one of the anxiety disorder. Please bear in mind, it's not only head injury, but they mostly refer to the more severe, more devastating, more disaster to the patient. So post-traumatic stress disorder, normally they apply to the combat situation, war situation, refer to the heavy earthquake, refer to the victims of the rape, refer to the hostage situation, dying and alive situation, child abuse, bullying. So trauma, head injury, normally they not refer to it, but most study refer to this scenario here. Because trauma, head injury, in some patients, they're not really distressed. Maybe you should classify which one has, which one not. So do study on that. That's another area that you should study. You can study while you're here in USM, because we have many head injury patients here. Under this category, you have obsessive compulsive disorder. Okay, you obsess to do certain thing. You must do that. You must do that before you go out. Obsessive compulsive. You must do that before you go to the toilet. You must do that before you watch television. You must do that before you go to see your parents. Something like that. Okay. So once you have stress in your mind, in the limbic, so as I showed the network just now, the whole body affected. Okay, the emotion, body, autonomic, cardiac, lung. So they are interconnected. Okay. So this again back to the neurotransmitter hypothesis. So which neurotransmitter involved in anxiety? So now the focus shift more to the serotonin. Serotonin one for anxiety, or even noradrenaline and GABA. Okay. So it's anxiety disorder, hyperactivation of the fear network. Which fear network is thalamus, amygdala, hippocampus, anterior cingulate cortex. ACC is the anterior cingulate cortex, striatum, sensory motor cortex, insula. So now you know where they are. I show you what is striatum. Striatum is caudate nucleus plus putamen. Ventral striatum, dorsal striatum, ventral pallidum, dorsal pallidum, pallidum. Okay. OCD, obsessive compulsive disorder, inefficiency within the cortical striatal thalamocortical loops or inhibitory. Okay. Parkinson disease, post-traumatic stress disorder, this generalized anxiety disorder, hypoactivation of anterocingulate cortex. All this concluded or conclusion met after the research, but still open to criticism. Okay, it's a selective mutism, school age. As I said before, addiction.
Can I ask you, this selective mutation, is that be also created by if you have a bullying at school, or this is completely disorder? I mean, it's nothing to do with bullying or other.
I don't know, maybe not, maybe yes. But I remember one or two of my patients in primary school, they have this selective mutism and they've not been bullied.
Okay.
Yeah.
So not connected with the bullying or combination.
Yeah, I think probably it's a network, brain network. Behavior, mood, behavior disorder. I think it's more to do with the brain.
Okay.
Maybe with the connectivity. Yeah.
Okay. Thank you.
Yeah. This one, the addiction, alcohol, drugs addiction. You see, the alcohol one, it tend to knock off both amygdala and hippocampus. That's why you lost memory, you lost fear, you lost behavior. Your behavior cannot be controlled, and then the blood knock off both sides, right and left, hippocampus and amygdala. So your behavior change. The blood, the alcohol level doesn't knock one side, so it always knock both sides, right and left. So that's the reason why probably alcohol is a dangerous or is naughty when you become intoxicated. If not intoxicated, it's okay. But when to draw the line between A and B, intoxication and non-intoxication, is difficult. So probably that's the reason why it's forbidden for certain country but allowed in another country. Okay. This one what the estimate. This one show the detail, more detail from my lecture. Amygdala, hippocampus. Okay, there's a thalamus, musculopallidus, dorsal striatum, ventral striatum, nucleus accumbens, all the stuff. And there's a prefrontal cortex, dorsal lateral, ventral medial, prefrontal cortex, anterior cingulate cortex, orbital frontal cortex. So medial, orbital, medial, and lateral one. The cingulate cortex, the anterior cingulate cortex, and the rest all this part. Very part of the limbic that play a big role in almost type of mood disorders. This one, the craving one. The craving one, they focus on the nucleus accumbens. Again, nucleus accumbens. The addiction as well. I think the Chinese neurosurgeon did the stimulation in the nucleus accumbens to treat patients with a drug addiction. But again, the outcomes, the result is not promising. 40% improvement But then patient have person have recurrent of addiction and so on. So altering the network, altering or changing the network is not easy compared to the alteration or altering of the motor or sensory network. I refer to the Parkinson. Parkinson, you have tremors or motor tremor, but when you stimulate the subthalamic nucleus or globus pallidus internus, the motor response is quick. But for the non-Parkinson, because or non-Parkinson, we refer to the mood disorders, schizophrenia, depression. They are not like Parkinson. Parkinson we can push aside because it's a motor more like motor disorders. But this schizophrenia, depression, addiction is more like behavior disorder or mood disorder. So when the surgeon, the doctor, tries to stimulate certain nuclei to improve the condition, it is not as same as the Parkinson one. It shows that to heal the mood disorder through the stimulation is not as simple as the motor motor improvement for Parkinson. It's not easy as like motor one. So behavior is more complicated. Don't know why. The energy for behavior is different, or maybe the network involved is more complicated. This one shows my sketch. My drawing shows the midline. When you go here, you see the midline. So this is a cingulate cortex. You have anterior, middle, and posterior cingulate cortex. And some you call it subcingulate cortex here. This area here, SACC, subcingulate cortex, where you have basal nuclear, basal forebrain nuclei. Yeah, around here, to do with sleep, to do with fear, and so on. And here the division between the anterior, middle, and posterior. So the posterior one behind is more like for your vision and hearing, and here more like for memory. The one that most for the limbic behavior is more like anterior one. The middle one for the motor and sensory one, the middle one. But for the anterior, more like for limbic or mood or behavior one. So that's why they focus more on the anterior aspect. Okay. I just skip that one. So this is the bullying. People hypothesize something to do with the bullying at school, and then person tend to be like LGBT or something. I'm not sure. I don't know. If you've been bullied and you've been isolated, separated from your colleague, from your friends at school, then you tend to be isolated, separate, and you try to find your own group, and that's what LGBT come about. I don't know. So okay. This again shows the arrangement, the systematic brain, how systematic they are. I think that's all for my lecture today for this part. Okay. Any question?
Prof.
Yeah.
Hello.
Yeah.
Prof, actually nak tanya yang related to the next week. Is that all of us need to do the presentation?
Just only one or two. You can change. You can change among yourself. Normally, what did before just only 1, 2. One present this part and one present another part.
Okay.
What I'm trying to say is, you all have to read. All of you have to read. Then I'm gonna ask you some question probably. Huh?
Oh, so we need to do some revision about the professor lecture last week.
No. You prepare the limbic network. Only prepare the limbic network. The anatomy of the limbic system.
Oh, okay. Thank you, Prof.
You just present that one. Okay. You want to go quick about the memory one? I go quick about the memory. Network for memory is again hippocampus. It's the same thing. It's a limbic system, also known as Papez circuit, right? So overview of it is the same thing. It's hippocampus. I go quickly. This is the hippocampus. It show like horseshoe like. the limbic system, I go quickly. Limbic, same. Prefrontal cortex. This one, the dorsal medial, dorsal lateral is a ventrolateral, ventral medial. Most limbic medial one. Even the lateral ones also get involved. Memory network, hippocampal formation. See the hippocampus, seahorse-like, infinite shape, like spiral-like. Most of the nature, the nature shape are infinity shape. If you go out, see the tree, see whatever you see outside is the infinity shape. Hippocampus, skip that one. I think you all know. I think I can show you this slide for you. You want to see this slide? The memory, you're talking about hippocampus. I think you pass. What's this? Brainwave, and that brainwave, mind, body, interact, brainwave. Wait. Cerebellum, mind, body, interact, brainwave. Oh, not this one. You see the video here? You see the video? That patient with the mood disorders. I show you the video. It's a before surgery. The lesion in the amygdala hippocampus. This patient got epilepsy as well. And mood behavior disorder, aggressive, or not talking much, autism, irritable, overactive, cannot stay still. Can you see it? This is after surgery. Can you see it? So improve a lot after the surgery. I'm going to show you one slide. If you're talking about the brain, the wave before, somebody asking about wave. Hello?
Yeah, yes, Prof.
You want to see that one? My slide. One Genesis.
Prof,
Yeah.
I want to ask, for, if I'm not mistaken, for ADHD and autism, their delta and theta too high for them because the part of the temporal and parietal part of the cerebral has the wave too high. Is that correct?
Temporal lobe in autism, they have hyperactivity in autism. Temporal
Same
lobe.
with ADHD.
Yeah, autism, ADHD is nearly under the same spectrum.
Oh, okay.
Attention deficit hyperactivity disorder, and autism. So under autism, many types of autism. So one of them is ADHD. So I think you can ask psychiatry on it. I'm not really good at it.
Okay. Thank you, Prof.
What I'm trying to say before I show you this slide here, the wave. There's so many waves. Why did not clash? According to the physics, because you see my picture here is a brown one. This is our universe. This is our current universe that forms. So there are many waves. The one that intersect our universe, the one that you can see. So there's so many waves, but the one that you cannot see is the one that not intersect. So this dimension, the one that beyond our universe, is infinite dimension. So that's one of the reasons why they are not hitting each other. The wave are not hitting each other. So our dimension is the lowest dimension, so 1, 2, 3 dimension. If you go outside, you see everything, whatever inside, outside, inside, all are infinity shape. This infinity shape. Helicon, leptilion, spiral, all are infinity shape. Whatever outside is infinite. Okay. This talking about the wave. Gonna publish in the journal. They are quantum physics basically. Probably no need for you to understand it. But I try to show you this slide here. So you are currently in the lowest dimension. So probably when you die, you can see higher dimension.
Prof.
Yeah.
Prof. For example, if we continue doing the usually I'm doing the neuro for the client with autism and ADHD. So we can change the pathway in the brain.
Pathway. Sorry, say again.
Is it when we using the EEG? So for example, we put on the T1, T2, C3, C4. So it can change it can help the brainwave to change the pathway of the brain.
EEG, no, EEG is just only recording. You record what the patient have. You cannot change anything. You just record. You can change the network. You can change the network by give medication. By giving medication or by give stimulation. Talking about just now, the magnetic stimulation. If you give the electrode stimulation, but if you just recording from the EEG record, you cannot change the network. What you have is what happened inside the brain. You recording only. You record only. Okay. You want to know about the brainwave? This one, the brainwave. Probably how to make it bigger? Or where's that thing? You see the brainwave. You have delta, theta. How to move this? Becoming difficult to move. Normal, comment, notes.
Please go to the next, the right side, next to the you know the change in the message.
Maybe it's hidden here. Yeah, hidden by this my imaging here. My computer hide it. Okay, here. Yeah. You can see the brainwave. You have slowing wave. You have hyperactive seizure like wave. I go quickly with you. This one, the kissing wave, or some people call it phase reversal. The kissing wave or phase reversal, because it's reverse, it's kissing each other. It shows a sign of the epilepsy. Okay, you can see here the sharp wave, sharp wave. This is a spike. It's not really sharp, but it's spike. That means it's more acute. For sharp. For the spike. So this is a brainwave that you analyze with advanced stuff. What I want to show to you is this one, the standard EEG. The blue one on the right side, the red one normally the odd number on the left side, the even number on the right side, and the coloring normally the blue one is on the right side, the red one is on the left side. So you have this FP2, FP1 frontal, F8, F7 frontal but more lateral, and you have F4, F3. The F8, F7 sometimes is record more in the temporal lobe. F8 and F7, even though the name F frontal, yes, but it record more on the temporal lobe, temporal pole. Okay, the T4, T3 temporal. So bear in mind, F7, F8, despite the name F frontal, but the signal mostly coming from the temporal. T5, T6, P4, P3, you have occipital behind. This is a midline, C3, C4. This is the ear. Okay. This is a reference. So this is the arrangement for EEG. So you record the wave. So you cannot you not alter it. You just record it. Okay, if you want to alter the
Okay.
wave, you have to give medication to the patient, or you give stimulation to the network. So the
Yeah.
brainwave, you have amplitude above and you have frequency below. Okay, frequency and amplitude. I skip.
Yes, Prof.
Understand?
Oh, yeah, yeah, I understand.
This more like advanced stuff, advanced quantitative EEG. This
Prof,
is kind. Yeah.
Prof, can I ask about the 1020 system just now? What is the location of the FZ means?
FZ central point.
FZ is for sorry, for the
Frontal central, parietal central. CZ central zone.
central zone. Oh, okay, okay. Thank you, Prof.
Yeah. You look in the literature. I think it's a zone that a bit on wave following epilepsy. So it's a spike wave. You see one? It's a polyspike, many spike. It's a sharp, slow wave. This is a sharp and a slow wave. It's a sharp one. Okay.
Prof.
Okay. Any question? Tak ada question. Salam.
Very quickly about selective system. I was
Hello. Tak dengar. Hello.
Hello, dengar tak, Prof?
Okay.
Can you hear me?
Okay.
Okay, related to selective mutism, aside from psychotherapy and behavior management, some of the parents ask about the medication. Is there any pharmacological treatment to help the children, with selective mutism?
Autism. Treatment for autism. Selective mutism.
Yeah.
Treatment for selective mutism. Oh, that one medication.
Medication, yeah.
Medication. I don't know. Ask the psychiatrist on medication.
Okay.
Yeah.
Alright.
Okay. That's all for today. So my future appointment with you all. So 1 or 2 present the limbic system and then we finish. Basically, I just want you to study on your own. Study where is the limbic system. Have you seen the electrode? This electrode inside the brain. This is a real brain. It's an electrode onto the brain. So you have very nice signal, very accurate signal, brain signal. This is direct onto the brain. We call it electrocorticography. Electrocorticography or ECOG. 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 Direct onto the brain. Okay.
Prof.
Yeah.
Sorry, Prof. If you don't mind, just now, Prof share the brainwave, and the picture, the wave is not too much synchronized. That one happened because of what, Prof?
Synchronized can happen in anything. In mood disorder, in anything. Can happen in anything.
Okay. I think the slide before this, Prof show.
Banyak this harmony apa semua happen in anything.
Oh, okay.
Okay.
Okay. Thank you, Prof.
Yeah. Okay, bye.
Thank you, Prof.
Bye.
Thank you so much, Prof.
Thank you,
Okay.
Prof. Goodbye.
So much, Prof.
Yep.
Thank you, Prof. Assalamualaikum.
Salam.